topic today is really more of a discussion about how to extend right touch regulation. It's already there in Ontario to a certain degree and other provinces. Interested to hear how people are coming along in other jurisdictions, whether federally that has the same resonance to it. A little bit about this organization. So Upstream Management Solutions, something started a couple months back now. And we focus on public sector consulting in sort of 5 key areas around policy research, user experience, learning strategy, and engagement of stakeholders. And one way we try to approach things is to really look sort of upstream. Where are the problems originating from? Where are the core problems that we need to deal with? And often we're dealing with symptoms, and to kind of probe a little bit further and look at a broader system. One thing you'll see there as a gift to you today is that you can avail yourself of an opportunity for a free, what I'm calling a pulse check. If you look at the letters down the left side.
I think we're still on screen 1.
We're still on screen 1. Okay. Any better?
I'm just seeing the home screen presentation mode.
Okay. All right. How's that? Are we in? How are we doing now?
That's working. Yeah. You're on
Now it's
screen.
working?
You're on slide 3.
Okay. All right.
Back
So
to 2.
quickly back to slide. Thank you. Always good to have assistance. We do offer a kind of a 1-hour free kind of audit. It's sort of a maturity model approach. Sort of where are you in the organization? Where are the opportunities to continue to sort of advance? There are different sort of stages of maturity or development of all of these sort of areas. And these are really, I think, core areas that apply to a lot of organizations and apply, particularly regulatory ones, in terms of how to use these kinds of tools to help you meet whatever kind of regulatory or other objectives that you have. So very shortly about me, I was working with Professional Engineers Ontario for the past 20 years, doing a range of policy, strategy, governance, CPD. Prior to that, worked with the Ontario Ministry of Community Social Services and did a secondment for a couple of years at the Cabinet Office, which was very eye-opening as well. And one of the things I did with PEO, and I recognize from Deborah and as well as Stamatis, is we formed a network of the Ontario regulators, which was both health and non-health. It ran from about 2005 to 2016, and got to, I think, share best practices and commiserate a bit and learn from each other. It doesn't supplant the H-Pro, the health regulators at all, but it was recognizing we're in a common space. And the nice thing is that we're more colleges are regulatory bodies have a more collegial approach rather than competitors. And that's an advantage when you have all kinds of different sizes of organizations and capacities. So we're just going to run a quick little poll here. Adina, if you can launch that. All right, thank you. Okay. So just to give a kind of a level set. Okay. We'll give it another few seconds if anybody else has come on. Okay. And there we go. Okay, so a good mix of as kind of expected, from fairly minimum or basic understanding of it to much more. Okay, so let's move on to that. We'll get over to the next slide. He said, there we go. Okay, so this will be probably overdue for some of you and maybe brand new for others. When we talk about right touch regulation, we're just doing a very, very quick summary of this. This is something that was imported from the United Kingdom in their work dealing with medical colleges, health colleges, and they came up with really an approach to look at what is the proper extent of regulation, and particularly applied in terms of health professions. But there's a lot of overlap, I think, with general approaches to regulation theory and that apply. And ultimately, you're trying to find that sweet spot. You're trying to find the balance, and it's going to be issue by issue. It's not meant to cover everything, but it's essentially looking at finding proportionality around the extent of regulatory intervention by an authority, and ultimately what's the public sector risk that originated, how much harm does it actually cause, and trying to find, again, the proportionality, the response that makes sense. And there are different elements and risks. So the PSA came up with this originally in 2010. They revised it in 2015. They are now in the process of doing some further revision, and a couple of slides later we'll talk about that. And essentially there are elements. Some of these you'll recognize as almost sort of standard approaches really to problem solving and to regulatory matters, which is obviously understand the problem, try and quantify the risks. I've identified, highlighting the things that are risk related here, getting as close to where the problem is, understanding the outcomes that you want to do rather than the process necessarily, trying to apply that only where necessary and only to that extent, keeping it simple, keeping it, very focused, and checking to make sure there are no unintended consequences. And of course, nothing is ever a one and done, but looking at this as issues continue to change over time. They have currently 6 different principles they apply. So it's not meant to be a prescriptive, hard and fast process that's identified that here are the 12 steps where there's no, it's not like a PMP. It's not, that you have that level of precision or you want to restrict it in any way for it. But obviously the principles to sort of use is that you want to be, again, dealing with proportionality. You want the rules to be consistent. They should be targeted, focused on where the problem is. They should be made transparent so it's clear to all parties within the system or outside the system what applies. So there is that applies to both practitioners, it applies to the public, whether it's governments or whether it's clients or patients that are involved. So everyone should understand what is there, and that makes it, again, there's no hidden agendas here. Ultimately, regulators have to be accountable to be able to justify why they made decisions. And this is also, again, interesting that while this was developed in the UK, they don't have the same level of self-regulation when it comes to their health professions as we do in Canada in particular, and Australia. So it's fairly unique, and therefore to be able to have that continue that level of self-regulation, that arm's length relationship, you've got to be able to make sure that you're not protecting the practitioners, you're ultimately protecting the public. And the more that you can demonstrate that so it's clear for everybody what the rules of the game are, that helps. And finally, that things have to be agile, that the organization has to be able to, recognize that things are going to change continually and to be able to try and even anticipate them. What trends, what directions are we going in? One of the tools that they've come up with, this worked better on a landscape screen. It's essentially a decision tree. So you can see the elements here on the top row and sort of focusing on understanding the problem, where the risks are, and it gives some early exits. So if there are matters where clearly there is no risk that's been identified, or there may be a risk, you can see in sort of the middle of the screen where it is, but it's being managed by employers, it's being managed by companies, it's being managed by perhaps another regulatory body with jurisdiction, then that's the end of it, that we basically say there's no need for those kinds of interventions to take place. And this allows for, as I say, a more dynamic approach to matters when we look at ultimately the decisions that have to be made. Okay, and if we're going to intervene, in some capacity, how do we do it? And there's many different regulatory measures that can be deployed, and can run from the heavy hand of legislation and regulations with the enforcement capacity all the way down to things that are more educational, things that are more instructive, that are sort of nudging activity, and they can take place in different locations. A little bit of a plug for the PSA. So they have a current discussion paper out on this in terms of changes, and I've left the British spelling of certain words there for their own charm. As you can see, there's some things that have happened as they're seeing it since 2015, and they're trying to again be agile and respond to those things. So recognizing that despite everything else, there have been some failures in certain sectors that we need to deal with. So it can be issues like people, working in multiple jurisdictions or closing up shop and with a shady past and opening up somewhere else, and finding where the weak points are, looking at ways to better respond to harm, recognizing there is much more complexity and overlap, a greater need for focus on prevention, and trying to take a more proactive approach to prevent regulatory failures rather than waiting sort of after the fact. And this is all in their particular discussion paper. They've also added, as we saw, the 6 principles that they identified from, again, the UK, that they thought should be added to this. And part of their proposal right now is to expect collaboration amongst regulators to work within their particular sectors. And of course, that decisions have to be fair. So in Ontario, we've actually seen quite significant action taking place. The collaborative one, I think to its credit, the health colleges have worked together quite well to identify ways to collaborate, not just to share sort of content and practices, but to actually develop tools that they all use. We'll mention a couple of them later. And there was interdisciplinary practice guidelines that reflects the fact that patients are multifaceted, and they actually there are overlaps, and they have interdisciplinary practice taking place in particular work environments. And so to recognize that that's where it happens, and there are some areas in between that we need to address. And certainly starting with Ontario since I believe about 2012, 2013, the Ontario Fairness Commissioner was created primarily to focus on registration practices and to ensure, more from a human capital perspective, that there is access and removing barriers to people who are immigrating to Canada, to Ontario, from internationally being educated somewhere else. So recognizing that that's been sort of their focus, and they've been kind of upping their game and getting more and more interested, shall we say, in what Ontario colleges have been doing. And we're now seeing this being replicated in many other provinces now have their own sort of fairness commissioner, and they're doing their own comments and propagation. So the UK, the Professional Standards Authority, is looking for comments by May 2nd. If anybody wants to do that, then certainly it would be advisable. But I think there are, again, many areas. And the other piece, of course, in the fairness is not just the registration aspects, but this is clearly the DEI work, or EDI, or whichever way you arrange the numbers, that has been a factor as well, and shows up quite a bit now. Okay, so we're going to run our second poll, our last poll for this webinar, and ask you this: check all that apply, and then we'll give you about a minute to just get a sense of where you're using right touch regulation, and make sure to sort of pull down the bar on here. Okay, does anybody need any more time? Or we're good? Okay. All right, so sort of review these. So interesting. And I've arrayed these in kind of from the entire sort of gamut, the whole sort of life cycle from the early education experience acquisition of a potential applicant or registrant and all the way through. That's how I've sort of arrayed it, and interesting to hear for those who are using it in the early stages, because I think that's quite novel. So practice, good to see. CPD is not showing up there as yet. Quality assurance and complaints and discipline decisions, definitely, and in discipline cases as well. Strategic planning, but and policy development. Interesting to see that that's showing up there. Okay, very good. So, all right, so I'm gonna get rid of that and go on to the next. He said, there we go. So when we sort of take a larger view, and again, this is going to be Ontario specific. So my apologies to our colleagues here from other provinces or from federal area. So there are two that stand out in terms of being mandatory that everybody, all the health colleges anyways, there's something called the College Performance Management Framework, the CPMF. And that's something that was imposed, worked with, developed by the health colleges, but ultimately imposed in recent years. And it really meant to be kind of I always say, a focus on outcomes to looking at. And there are two of the measures that they identify that specify right touch regulation principles being used in both quality assurance and the complaints process. And that's why clearly, fully expect to see it showing up at least in all of the Ontario health colleges. And it's something they have to report every year to the Ministry of Health. They did a summary on that. Another one where we see it very common, especially again, health colleges, is something called the risk assessment framework. And that's really dealing with the complaints stage with the ICRC, the committee that deals with complaints, investigations, and sort of makes decisions to forward or not forward things onto the discipline committee. And we'll talk a little bit about that as well. I'll show you something on that. Seeing it more and more showing up in terms of as a value statement within strategic plans that we will use right touch regulation, even if their things aren't necessarily specified. See it to a certain degree showing up in some practice guidance or advisory, to a certain degree in stakeholder engagement facility activities. Policy development, glad to see from at least our small poll that it was showing up more as issues are being looked at. And I think that's again, perfectly fair. When you look at the new things, it's easier to deal with those things than necessarily looking systemically. Less common to see things in registration practices and CPD. And I've got one example here just recently, the Law Society Ontario, not a health college, looked at sole practitioners and identified certain risks and said, you know what, rather than wait for them to show up at complaints, let's introduce some mandatory continuing professional development for those who are working as a sole practitioner, deal with the kinds of issues that they're likely to encounter. So it's a good example of that. I've put in a few exemplars here, and not meaning to diss anybody who's not, college isn't on the list, but some things that show up in terms of those, the quality assurance ones. So we clearly see things that are more risk-based approach as to who gets assessed for a QA. So on that basis, identifying those things, looking at, again, different models here of looking at the practice risks, trying to categorize them there, some earlier interventions, that you see show up in a few places, whether it's coaching or whether it's something more advisory, focusing very much on really where the individual, for the most part, these are self-assessments by practitioners that identify what the risks are. And I think, over time, where we can do more targeted audits. If you're going to do a random audit, then, you don't need to have a particular risk factor. If you're going to now justify why certain groups, certain subsets of practitioners need more attention based on certain, you have to identify what those common risks are that at least are an early indication. They're not necessarily prescriptive. When we look at, again, the aspects of complaints and discipline matters, so again, part of the CPMF approach, you'll see that all of the health colleges are using this framework. I'll show an example in the next slide. And different ones are using it. Again, most of these are typically at the complaints stage. So identifying where the lower level risks are and trying to either triage them based on harm potential with CPSO. You might be able to divert certain things. There's also the College of Nurses has some risk-based triaging as well, and others, you're sort of moving it along. And that takes us to an example here. This is from again, all the health colleges have been using this called risk assessment framework, and they've taken it and modified tools here. But basically, when you look at the kinds of issues that arise, now, of course, this is going to be somewhat specific, as you expect, to psychologists, but understanding what the impact risks are and recurrence, and having a series of indicators and identifying those 4 categories of risk. So the no or minimal risk results at the bottom in terms of no particular action need to be taken on those things. And there might be something more at the next level where there's some advice given to someone in the low risk category. So you've got, milder situations or sort of first offenses, perhaps, depending on the type of allegation that they're looking at. And again, moving up on the moderate level in terms of cautions or undertakings that they got to do, or putting in terms of limitations, conditions, perhaps on a practitioner. And then some of the things that are clearly higher risk areas. So we're looking at more patterns of behavior that are showing up, or very egregious sort of activities, and referring those often, pretty much always to discipline. So it's, the more that can be published, it's available to practitioners, it's available, potentially to clients or patients who might be filing a complaint, in terms of understanding, do I need to file a complaint? Should I file a complaint? What can I expect, the result to be as that goes? So that's been in place now since 2021, and continue to work with it and make improvements. And it'd be, I think, very valuable for non-health colleges to at least pick up the ball and look at that. So where I wanted to sort of pivot next is really, that's great in terms of where we're at right now, that we've got a handle. Colleges, regulatory bodies have a handle at least of where the risks are showing up at the complaint stage, or there may be things that are showing up at the quality assurance stage. However, the cautionary part of this is that it's really dealing after the fact. You're identifying matters, and should we be, in fact, as the PSA has said back in 2017, really focusing much more on the prevention aspect of it. And the good news is that we can make use of the data, we can make use of what we've harvested, information that is real in terms of complaints showing up, and we've categorized these things, and we can now take that information and move it. So where does the value to this go? First and foremost, perhaps for some, Complaints and discipline cases are extremely expensive for colleges, for regulatory bodies to operate. You've got lawyers on both sides. They can be quite involved, take a tremendous amount of time to finally resolve a case, and they are quasi or pretty much judicial. So there's a very high standard, and they have to, we have to make sure. So if we can prevent some of those things from occurring in the first place, we will avoid costs. I think we can probably apply it a little more strategically if we can take the information, apply it to registration practices up front, that maybe we can reduce some of the Fairness Commissioner issues when it comes to international trained individuals, applicants, and look at those things. I think there's also a value here in demonstrating to the public and to continue to promote self-regulation, is to say these are the risks that are out there. We've identified them. We've made it clear to the practitioners as well as the public. Here's what those things are, and it'll continue to change over time. But we are clearly aware of these things. We're not pushing them aside. We're not sweeping them under the rug. We're not giving anybody a slap on the wrist, and finding ways out of it. And in doing so, we demonstrate a lot of public transparency, which is, again, a very important factor here. It also helps to align with modern regulator models, where we want to be attuned, we want to be efficient, we want to be effective, and using, like most companies do, of all sorts, some element of risk management, that it behooves us to at least be in sync with that, and also making use of all of the data that we have and to use it to propagate it across the whole regulatory regime. It also supports, I think, something that's been gathering some steam, which is a term called relational regulation. And that is, sort of finding a balance here. We don't want to see practitioners as the enemy. We want to help them. Yes, we are in a position where, as regulators, we have to discipline, we have to explore, handle complaints, we have to do quality assurance, we have to set particular standards. But recognizing we're dealing with human beings who have, like all of us, have potential failures and weak spots and moments, or things that are just not so clear, or brand new areas that are developing that we haven't figured out yet. How do we deal with AI in what practitioners are doing? How do we deal with a lot of those elements? And some that a lot are dealing with, social media use and misuse by practitioners. So those are things that clearly take up a lot of time and energy. And if we can work with the registrants, with the practitioners on the education and prevention front, then that will help. And finally, it promotes, I think, a much more robust discussion and engagement with stakeholders. It's a very, very focused kind of discussion. It's not just a values and aspirational discussion. It's okay, here are the risks. Let's actually talk about the risks. Let's quantify them. Let's try and understand them, and where and how they arise. So I'm going to give you sort of 5 suggested strategies to look at, to sort of get us moving in, I think, a little bit further across the regulatory regime. Is first of all, and this is more of a fundamental approach, which is moving from that reactive model. We're looking at complaints, we're looking at things that are coming out of quality assurance. And in fact, can we anticipate, can we assess and avoid practice risk, and doing this all proactively? So what can we be looking for using the data? Secondly, I think we need to do much more research around identifying and assessing those risks and harms on the aggregate level, recognizing that what goes on sort of beneath the iceberg is a lot more of issues and concerns, but just they don't never make it to the level of a complaint for one reason or another. They aren't filed. And there are things that already are mitigated by employers. They have processes to do quality checks, to do all kinds of other assessments, and they catch the problems earlier on, so they never show up at a regulatory body as a complaint. So again, recognizing what those are, And we may not need, the regulator may not need to do that, but at least we have a much better sense. What are the risks overall and what is going to get us further along? In terms of understanding the risks, looking at its likelihood, its potential impact, looking at the kind of harms, so identifying those things in a very tangible way, understanding where, when, and how the risk is happening, what kind of situations, what frequencies, locations is this taking place, if there are systemic issues, or where is it showing up, who's causing and who's receiving the risk, who has control over it. Why is this actually happening? Is it based on behaviors? Are there unintended incentives or disincentives that may affect things in terms of how people operate that cause certain behaviors or certain actions to take place? So most practitioners, one way or the other, are still, trying to make a living. So there are all kinds of potential challenges from employers, perhaps, in terms of profitability, how much time you can devote to a particular client or patient. There may be incentives or things that happen from suppliers, whether it's materials, technology, et cetera, that might be causing that, or funding, if it's health colleges and it's something that's patients are or clients are being reimbursed for certain levels of coverage by supplementary insurance, so that can affect how much service they get, when, how long, et cetera, and where there might be some things going on. So not everything is entirely at the practitioner's control, but it's certainly identifying what those things are, and ultimately trying to identify where do we think we can perhaps avoid some of those risks. So some of the occupational harms, I'm dividing them into sort of occupational health and non-health related things that occur in practice that I think we need obviously to better understand. Obviously I put sort of the scale here in terms of what we're looking for as those harms. Non-improvement, it might be a delay in treatment, or we prematurely terminate the relationship, even if they aren't at full rehabilitation level. There could be additional injuries that are caused in the course of the treatment. It could be increased pain. Of course, sexual abuse is something that comes up a lot in health colleges in particular, the ones where there is contact, and those are things that are obviously of a criminal nature as well. And so there are different reporting requirements that go in there, but are there matters that we have to be paying much more attention to, distress, anxiety, ultimately death. And on the non-health, certainly impacts that people can identify as harms. So can be for both the patient, or even for the somewhat the practitioner, loss of income, concerns about fraud, about theft, overall team performance, liability issues, advertising. You can have project delays that have a financial implication, unsafe products being released or constructed, and non-compliance with legislative requirements that could result in penalties. And there could, of course, be criminal acts that get identified. When we look at, again, the source of data that we have right now around complaints, it's really a gold mine to look at in terms of let's break it down. Can we look at demographic factors that show up that might tell us there's greater or lesser likelihoods of things happening, again, based on what has been reported, what has come forward. It may not be the sum total of everything. To at least be able to identify these things as factors here, maybe where they acquire their experience. There could be certain countries, there could be certain types of education that might be more or less problematic, prior history. And then there are things that, again, risks that happen within the professional context. So looking at where there are, what's the scope? Are people going beyond their scope of practice, or their overlap with other disciplines or specialties? Are there particular activities that are carried out, or investigations or therapies that essentially present greater risk? type certain industries, again, that may be more in the non-health realm, where there are certain industries that are more prone to other things going on. The level of technology usage, the intensity of it in daily practice. So these are things that, again, can cause concerns. So again, we want to make sure that they're not guarantors of, just because you've identified risk factors does not automatically anyone is guilty. These are things to at least justify why we're looking at a more targeted approach. So we don't have we can't say just because things are correlated that there is a causal relationship. On the third strategy I'm suggesting is to be able to kind of start taking the QA and the complaints data and working backwards across the stream. So what can we learn from the things we just identified around risk factors? Can we start looking at ways of adapting or modifying our existing earlier regulatory functions? And just visually here, just to be able to sort of work it backwards to look at the risks, and ultimately you want this to continue to develop and to be refined, that you identify a lot of these things and they start to influence each other. In terms of where to start from, wherever you happen to be is the best answer. I think most, again, are likely to have, and the most productive data to look at are your complaints data. And there you can say, these are legitimate, these are complaints that have been filed, that have been adjudicated by our processes using our statutory requirements. And what does this tell us? If we start to break them down into those categories that may suggest where we want to put in place certain earlier interventions, or at least to be able to scan for things, looking at, are there correlations? I recall hearing years ago from the Law Society that they had a very high correlation between people who were complained against and people who were non-compliant with their continuing professional development. So if they're already, failing to be governed in their own personal conduct, there is a certain correlation likelihood that it's going to show up in complaints. So can we deal with these things early on? And here's a little suggestion for those who are in the health colleges, where there may be opportunity for a right touch regulation working group. I know they have lots of different working groups and committees and task force, et cetera. But it might be something to continue to sort of work on. We want to look at, again, make sure that our data sources are not just limited to, what we've currently and what we think we see. So certainly talking to practitioners, and this is all part of I think, the stakeholder engagement and really making sure that we've got a much better systemic understanding. So talking to employers of those practitioners, where are the risks that they're seeing? What are the kind of things that come up? And they may very well be mitigating them there. Talking to the member associations, most professions tend to have that. Obviously, is there clinical industry research that we can point to? Insurance claims, litigation on the legal side, malpractice. Can we look at our CPD or our quality assurance audit results and whatever sanctions were there to be able to do that? And of course, we can't leave out the really awful news stories sometimes that come up that make the press, that clearly are indicating a particular type of risk, and depending on the level of journalistic investigation. Number 4 is, I'm suggesting this is not a quick fix either. We need a multi-year plan. We want to sort of look at the propagation, the extension of it, and really sort of being strategic and saying, okay, we're going to start from here and we're going to work our way back, or we're going to develop in levels to do that. And that's an important way. Can we, for those who are working in areas where you have related colleges or related areas of practice, or even just common areas, if there, for example, anytime there are financial considerations involved. So there's a lot more in common between certain regulatory bodies that you wouldn't necessarily think of. You've got investing funds, or you've got deposits on things, or trust accounts, right? So there's more commonality. So we have to think a little bit broader here, and where we can gain in terms of best practices. Suggesting a few other areas that we can explore down the road that help user experience, or also called human-centered design, is something to really understand people and what is driving decisions on the individual level, what kind of factors. People are not always rational, and where they interact with either patients or clients, or with the regulator at certain points. Understanding what are the motivations, what are the kind of pain points that go there, that help us to come up with, I think, more effective methods of prevention. And the more that we can engage people through stakeholder and partner engagement, we are going to find ways that are going to work. It's not just the regulators pushing these materials on. These are things that are identified by people who are hopefully good professionals and ethical, and they want to improve the overall profession, and they're going to help us with those things. Learning and development strategies that we can talk about for both practitioners in terms of professional development and advisory issues, as well as for the individual staff within those colleges. And I see some other opportunities around sectoral collaborations. So can we work within certain groups? Again, it could be very functional in terms of this is the type of work we do, and we can gain from each other, or it could be very much specific to the actual area of practice. So you might have therapists in working in a particular thing. So if you have the occupational therapists and the massage therapists and the physiotherapists and others, perhaps chiropodists, who are sort of inhabiting a certain common space. So there may be opportunities there that identify things that are common. And also, I think you're going to see more where you have wherever you have interprofessional collaboration happening at the practitioner level, then it's going to show up here. And lastly on this, maybe somewhat controversial, but I think it's something worth discussing, where there are regulators, a significant number of them, who still are both the regulator and the provider of professional liability insurance. And it has some potential for some conflict of interest. If you're trying to, on one hand, discipline people, and on the other hand, as the insurer, you're trying to limit those things. So need a little more, at least an arm's length approach, and maybe even more divestment. Again, just a thought on this kind of approach. And so to sum up, we're looking at sort of 5 strategies, moving more from the reactive to the proactive, more research around identifying, assessing risks on the aggregate level, trying to incorporate and integrate those risk factors from our complaints and QA, move it across the regulatory regime. So both towards the discipline side, in terms of what kinds of penalties or sanctions should be applied based on certain types of risks, and moving it back on the other way, really upfront, to talk about education. What can we educate? How can we better educate our future practitioners to avoid some of these things and prime them? How can we work better on onboarding when we do registration? How can we help support that through standards and guidelines that we put out, and the advisory services that we provide? How can we provide this focused approach more within our continuing professional development? And again, all based on the kinds of risks there. And ultimately trying to put this together in more of a multi-year integration plan with some collaboration and the consideration around liability insurance. So thank you again for being very patient and listening today. I want to hear questions, comments you have on this. we'll sort of keep the floor open, and I think I'm gonna end the slides. I'll just do, while we're thinking about that, I'll just give a highlight in terms of a couple of things coming up. We're going to be doing monthly webinars. This is the working schedule right now for May around upstream problem solving, looking at how we can solve those things. And then dealing with user experience strategy, stakeholder engagement, and learning. And more information here you'll get. Again, everyone's going to get a copy of the slides and a copy of the recording. But let's open it up for questions.
Jordan, it's Stamatis. I just got
Yes.
a quick question. I'm familiar with the risk-based, and I remember reading Malcolm Sparrow's book, and I guess my concern working with the College of Occupational Therapists is I know the numbers tell a story, but sometimes, at least in our case, we don't get as many complaints. We don't get as many. I mean, our volume is small compared to, say, the bigger call. Like, I believe last year we had about 30 complaints, which when I was working at the nurses, we would get that like in a week. So how do you based with that limited data, how can you sort of like, can we still use it, or is it because it's a small number, it's maybe hard to I guess make a correlation?
So good question. I'd give you a couple of options here. I think first of all, talking, because you're an occupational therapist, understanding the work environments in which they are employed. So you have people who are in private practice themselves. That's one group. You have another group who's working in a hospital or working in a facility where there is an employer. And I think talking to them may give you a better sense of what are the other risks that occur that perhaps are caught early, that are avoided, that are still present. Are there, if there are targets, for example, in terms of rehabilitation timeframes that are imposed by or constraints imposed by a hospital. We've got to get people out the door. We've got to get them, or we've got to get them as a result of a automobile accident. We got to get them back to work, and we've got to rush certain things, and there may be some pressures that arise. The other thing I'd suggest is maybe talking to some counterparts in the College of Physiotherapists and massage therapy, perhaps. There are common risks that might be showing up, and for one reason or another, they're more prevalent or less prevalent, to be able to do that. But I think opening up the discussion with your practitioners and trying to be as non-judgmental about it is a way of trying to get a handle on it. And again, the data is a starting point. It's not the end by a long shot.
All right, thank you.
Okay. Any other
So
questions?
I've been
Challenges?
dealing with a really unusual situation. I've lived and breathed right touch regulation for 2 decades and done all of the things that you've talked about. And then with all that experience, I come to work with a brand new federal regulator where the licensees have never been regulated before.
Mhm.
The first thing they had to do was to figure out who their licensees were and where they were in Canada. And then to come to realize that there is no historical information, there is no complaints data, there is nothing. And so you begin to regulate this group, and they then implement mandatory insurance, definitely arm's length, and there is no sharing of information, even in the aggregate, from the insurer. We then find that 50% of the licensees are also regulated by another regulator. And so they tend to be dual professionals. We have no information from the other regulator about these professionals. And so we literally had to start from scratch. And the best thing we were able to do, I think, we'll find out, is this year, this is the 3rd year of operation, we're requiring as well as requesting information on the annual licensee report to say, what type of areas do you practice in? Where are you? What type of clients do you have? How many clients do you, we're trying to actually construct a picture of the profession that we are completely working without and in a vacuum in relation to. And so that has been, so when you describe, and everything you said was absolutely on point, everything. I've done it. I agree with you 100%, and it works. To then face this situation where you're trying to operate in a complete vacuum of information, just for me has highlighted how incredibly effective and important right touch regulation is to regulation. Because all I'm seeing is just how bad it is without it.
Okay, great. A couple of suggestions, I guess. Sometimes the best indicators are complaints to the minister. So in the absence of a formal mechanism, or if there have been news stories, people go to the press and complain about so-and-so. They ripped me off, they didn't do a good job, etc. So are there starting points where you at least have the discussion? Here is a list of things that show up. And I'd also suggest that finding allies in other federal bodies, perhaps, if they're, have dealt with similar things, or other professions, other activities that you can draw from, and certainly provincial counterparts, if you have the same body in other provinces, it's one thing. If you're federally, are there other professions or groups that are similarly regulated, or to some facet, you can start pooling the resources. I would also suggest having a chat with Treasury Board Secretariat, who is usually big on risk management, and see there. And the other, on the patient or client side of things, groups like the Consumer Council, there are consumer bodies that you can talk to that are set up nationally or provincially that can provide that. There are, having that kind of as a counterbalance, I think is good there. At least you have some information, some data to start with, and at least you're going to be starting that. I think clearly the getting a read of what activities they're involved with, and where they see if they're trying to develop as a profession. Okay, here are the things where we want to weed out the bad actors. Here are the things we should be looking for. And maybe the educators, if there is a process for registration that requires some educational background. So what is being taught by whom to get there, and what information do they have around the pitfalls potentially to be avoided. So you may have to sort of take a wider lens and think more broadly on that. Lee, you're muted.
If I could just add, we're the only other federally legislated college. So anytime you want to chat,
Okay.
I get
I
your
wasn't
dilemma
going to say
completely.
anything, but you
Yes,
know what I'm
I've
talking about.
I've actually, when we first were moving over, had conversations with your CEO many times, and yeah, very much the same issues.
And maybe
Exactly.
other countries, I don't know, are other countries farther ahead on these issues that we can at least
Oh,
in the
yeah.
English speaking world
Much
that are
further
much
ahead
more
than we are.
consumer protection oriented.
Well, we hosted a research symposium for the past 2 years, and we had the people from UK, Australia, and New Zealand there, and brought some academics in as well. And yes, they're much farther ahead, I think.
Okay, great. Deborah, did you have anything to comment?
I have to scoot out, but just wanted to say thank you for this. And we're just in the early stages as well. So we're just learning as we go, using data from many sources. including the inquiries that we receive and various program themes, that type of thing. So, we are just kind of, as we say, flying the plane as we build it.
Right.
And I'm sure that's the case, across the board here. And so we're learning as we go, and this will be a very interesting approach that we take. But I apologize, I do need to run to another meeting, but thank you so much, Jordan,
Okay.
for the session. Take
All
care.
right. Thank you all. All right, and hopefully, if you're interested, we'll see you again in the next month for another
Thank you,
talk.
Jordan. That was very
Okay.
interesting.
Thanks very much. All
Thank you
right.
very much.
Okay. Thanks very much. Take care. Bye-bye.
Bye.
Bye.